Good morning. I'm filling in for Andrea Austin, so this isn't going to be her talk, but I'd like to talk about acute compartment syndrome, the other ACS. I have no financial disclosures, and what I want to take this approach apart is just to talk about the medical legal risk, because everybody will get sued in this room if you listen to the stats, and this is one area that's really kind of taken off. All of us have gone to, I want to start off with a story. All of us have gone to birthday parties, and one of the common ones is ice skating rinks. So I'm sure all of us have probably seen a little girl that's come in with a little buckle fracture from falling on the ice. Well, this was a story of one girl that came to the ED, got a splint, went home, and then cried the whole night because she was in pain. Went back to the same ED the next day, they redid x-rays, the fracture looked fine, sent her home, finally follows up with the orthopod a couple of days later, has acute compartment syndrome, and this is what she looks like today because she lost her arm. So I just want us to, even though the mechanism and the injury might not look severe enough, we really got to take their complaints of pain seriously. And this might have been more crush injury than the actual break causing the compartment syndrome, but just realize the patient's complaints of pain can have some serious predictors of their ultimate morbidity. This is becoming a huge area of liability for the orthopedic surgeons, but the lawyers are really smart, and they know the person that touched them first was us, emergency medicine physicians. So they're pulling us into all the lawsuits because they'll say that we delayed getting them to the orthopedic surgeon or we didn't measure pressures. So we have to be really careful of acute compartment syndrome. In 2004, the average settlement was $426,000. But now I'm seeing lawsuits up into the millions of dollars. The younger they are, the more zeros you can add onto the lawsuit that they're asking for. The other issue with these malpractice complaints is 20% of malpractice suits will end in a judgment for the plaintiff. So 20% of claims will actually pay out something to the plaintiff, but in acute compartment syndrome, 50% pay out. So your chance of winning really comes down to a coin flip if you get sued for acute compartment syndrome. So it's just something that you really need to pay attention to. And this is why the lawyers are smart. They have conventions just like us, except you have to belong to the plaintiff's bar to get into their convention. I've tried. They won't let you register. But this is one of their websites, and they talk about all the complications of acute compartment syndrome. And we know them: permanent nerve damage, disfigurement, scarring, infection, death, renal failure. They also have on their website the chances of them winning a negligence case. So these are the things that they look for in a case. They love acute compartment syndrome of the lower leg because that's the most common area. They love it when it's the anterior compartment because it's the most common and we shouldn't miss it. But they love that we forget to measure the deep posterior compartment. They'll get us almost all the time if we don't actually measure pressures. And I think that happens a lot because we try to pawn that off on the consultant. We'll think about compartment syndrome and transfer them to the tertiary care hospital hoping that they'll measure the pressures. And sometimes things get missed and the opportunity is lost. And this is the one that really worries me, is they like it when the patient couldn't complain of pain. So our inebriated patients, or the ones that are comatose for some other reason, we should be at least feeling the compartments. Just run down your hand down their legs and make sure there's nothing that feels really tense. But they love those cases. And these I don't think we have a fighting chance against, but it just worries me that that's what they're looking for. So I just want to review the 5 Ps of compartment syndrome. So everybody kind of should have these memorized. It's pulselessness, pallor, paresthesias, paralysis, and pain. But the only one that really matters to us, I think the only one that we can really have a real effect on is pain. If you see the other 4, and then the cat's really out of the bag, and acute compartment syndromes are really a big concern. But we can get them at the pain. So pain with passive flexion of the limb, pain out of proportion to exam, those are the things that you're looking for. As a matter of fact, the lawyers teach, and it was on that slide, that if they have 3 of the Ps, they have a better chance of winning the case because a compartment syndrome is really likely. So if you're seeing paresthesias, paralysis, pallor, any 3 of the Ps, then you should say it's acute compartment syndrome until proven otherwise and refer them on to somebody else and don't take on that liability risk. So I just want to review how to make the diagnosis. Of course, you got to think of it. That's always the first step on any of these. But it really comes down to measuring the pressure. And I think this is where it's definitely in the purview of emergency medicine physicians, but we typically pawn it off onto our orthopedic colleagues or the general surgeons if we don't measure the pressure. So this is the Stryker kit that we should all have. There's even this newer kit. This is the Centurion Compass. It's a single-use pressure gauge that you can use with any syringe or needle. But with either of these pressure gauges that you're using, the pearl here is read the directions. I'm a big tech guy, and it takes me 2 weeks to read the directions for anything when I can't figure it out. But most people don't use the Stryker kit right because we don't use it frequently enough. So you got to learn you got to reread how to calibrate it, how to insert the needle at the right angle so you're getting accurate measures. But we should have these in our EDs and be measuring the pressures. We shouldn't be pawning it off on somebody else because then there's a delay. But when you call the orthopedic surgeon and tell them they have a compartment pressure of 50, they're going to get the OR probably ready and other things as opposed to getting to the ED. And then you guys have seen how long sometimes it takes to transfer patients. All that time adds up, and you're on the hook for the amount of time it took to get them to the definitive care. This is the number you need to know. We used to memorize 20. If the compartment pressure was 20 or higher, they had acute compartment syndrome, but it's changed. Now they want it to be less than 30, and that number, less than 30, is diastolic blood pressure minus the compartment pressure. If that's less than 30, then they have acute compartment syndrome. So it depends on their blood pressure. So if their diastolic blood pressure is 80 and their compartment pressure is 20, the difference is 60. They're good to go. They don't have acute compartment syndrome. You might need to monitor them and watch them, but nobody's going to cut their leg at that point. But if their diastolic blood pressure is 50 and their acute compartment pressure is 30, then the difference is only 20. It's less than 30. They have acute compartment syndrome. They're going to probably do a fasciotomy and release the pressures. So you need to know the difference. You'll see some people mentioning that it's the mean diastolic blood pressure, but that gives a higher number. I would go with diastolic blood pressure because it gives you more wiggle room. Ultimately, it's up to the orthopedic surgeon, but you got to figure out what the difference is between diastolic blood pressure and compartment pressure and report that out. So how do we heal? The big thing is we can do fasciotomies if you're in a really remote places. I think most people refer them to a general surgeon, orthopedic surgeon, but our biggest rule is to first do no harm. And this is the one mistake I think a lot of us make is we elevate the legs because they're swelling. But elevating the legs impedes arterial flow, so you actually cause more ischemia. So keep the legs supine or neutral. Don't have them down, don't have them up, just keep them neutral, and that'll give them the best chance of keeping the blood flow to the legs as much as possible. My 6 minutes and 40 seconds are up. I hope you guys learned a little bit more about compartment syndrome, and I'll take any questions.